Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm your host, Dr. Keya Locke. I'm joined today by Dr. Joseph Staggenborg, guest editor of July's ASA Monitor, along with Dr. Robert Johnstone, whose knowledge and experience with practice management is inspiring. Both are also members of the Committee on Practice Management, and they're here to talk to us about the role of strategy in practice management. I'm looking forward to learning from both of you, so welcome to the show.
Thank you.
Thank you.
And before we get on topic, if you both could give us a short introduction and please touch on where your passions for practice management stem.
Sure, I can go first. I'm Dr. Joseph Staggenborg. I'm a clinical anesthesiologist with Team Health. I work in the Florida region. I'm also the vice chair of the Committee on Practice Management. My passion for practice management really came from experience. I was very fortunate in my first job. I had a very high functioning operating room. First case on time starts were, 80%. Turnover times were under 30 minutes. Everything was great. And then I went to a very poorly functioning operating room. And it was just really a matter of survival to learn how to make the place a better place to work for myself and my colleagues.
I'm Bob Johnstone, a senior anesthesiologist. I'm actually in my 60th year of anesthesia practice, so I've seen a lot of changes. Most of my career has been in academic anesthesia, primarily at West Virginia University, but formerly I was in the U.S. Army in an anesthesia role and in private practice. Going back to the Vietnam War era, where I was anesthesiologist in Southeast Alabama, I was eager to maintain academic stimulation, and I used my GI Bill for free education down at the local university. My two choices at that time were either an educational track for teachers or business school. So I went through the MBA program at our local university, and it was my recognition that, wow, there's more to organizing an anesthesia group and running an anesthesia group than just science knowledge. And that was probably where personally my interest in practice management began. And then life has been good for me. I've been fortunate to be involved with organized anesthesia for multiple decades as a component secretary, treasurer, and president, and then as an ASA delegate, director, and the vice president of professional affairs. And during that time period, I chaired the practice management conference and committee many years ago. I chaired it for about 5 years.
Wonderful. Dr. Johnstone, it's great to hear from you again. I had the pleasure of meeting you at last year's practice management, and you just have such a wealth of history, especially as it pertains to practice management and the committee itself. Can you tell us a little bit about how the committee has played a role in all that you just spoke of?
It has played an incredible role. As I said, I have a long history, so I've seen a lot of changes. If you go back to the 1960s, there was a totally different culture for professionals in the United States, and that was that you didn't consider finances with anything, that it was really kind of unethical for physicians or lawyers or other groups to factor finances into their decisions. So it was considered, for instance, ethical when considering patient treatments to talk about risk versus benefits, but you never considered costs. And that started changing. In the 1960s, the lawyers won the right to start advertising. The ethical principles changed. Costs of healthcare became an enormous issue, and it changed decision making. I would say then, following that, in the 1970s, there were 4 things that I can think of that are really important in sort of the founding of practice management in anesthesiology. First was the change in ethical principles, that it was not unethical to consider business aspects, but that it was actually ethical and important to do that. In the early 70s, an ASA president, but before he was president, Bernard Wechsler, helped originate ambulatory surgery centers. And of course, their big selling point was lower costs and more efficiency. So that started gaining ground in anesthesia, that we need to really consider that. A third thing was value-based anesthesia became a important, really important concept. And that was factoring more than just risks and benefits, but risks and benefits and costs into practice. And then I'd say the fourth thing was rising threats to the specialty of anesthesia from scope of practice, from Medicare, and that it became very important for us to get involved. And maybe a fifth one, the ASA had a consultation program where we would visit at the request of hospitals in anesthesia group, review them for quality. And what we found was that it was not always just quality, it was frequently money was tied up into it, finances. They weren't doing a good enough job, that group, collecting their money, managing their money, wasn't doing it wisely. But when we started, for many years, we were not allowed to consider and did not consider the finances, and it just became too important. All of those things kind of coalesced into the founding of practice management. We might have called it business of anesthesia, but the business word was sort of forbidden at that time. And that's how the name practice management came about. The Practice Management Committee was really founded about 1993. The practice management columns in the ASA newsletters then started in 94, and in 1995 was the first practice management conference. And I was lucky enough to be on the original management committee and conference. And wow, what a history it's had. And I'm really proud of where it is now.
Yeah, that's it. That is just amazing to hear. And as you have alluded to, practice management is an enormous topic, and it's one we've covered on Central Line from various angles. But you chose to focus on strategy for the upcoming issue of the Monitor, and I want to focus our conversation here on that as well. To get us started, can you tell us why, of all the lenses through which we can view practice management, you feel strategy is particularly important?
Sure. Thank you, Keya. So we live in an era of limited resources in a dynamic environment. You've got so many issues going on. You need to have a plan. You need to minimize the loss of your resources, and you need to maximize what we can gain. We talk about negotiations, the science of negotiations, and the postmortem, and it's a concept of a Pareto equilibrium. And that's when you're done with a negotiation, decide whether did we leave money on the table or did we spend too much. So that's really the whole purpose of strategy, is to get to that Pareto equilibrium. As far as why we chose strategy, this is the second time I've been the editor for the Monitor. And last year, our theme was a theme of no theme. And you can only go to that well too many times. So we had to come up with something different. We had an idea of, what we wanted to write about, the stories we wanted to tell. And we were at ASA Advance last year, and we were trying to come up with a unified theme, and we just couldn't come up with one. And I remember riding up in the elevator, and just the word strategies popped into my head. And I texted all the guys, and they're like, yeah, that's exactly it. So that's how we arrived at strategy. And, strategy is a broad term, right? There's strategy in negotiations. There's strategies in staffing, in dealing with angry people. There's strategies.
I like the idea of strategies because it involves anesthesiologists making decisions. If we go back to the beginning of the practice management conference, what's now called Advance, the speakers were all non-anesthesiologists. I just was looking at the 1998 conference, and 2 of the 16 speakers were anesthesiologists. What's happened now, if you go to it, go to the Advance meeting, It is mostly anesthesiologists. So I think that's a nice way to organize it and to get people involved.
Thank you so much. Let's turn to some strategies that can benefit listeners. What kind of strategies can you use to manage conflict in the perioperative setting, dealing with, say, an angry colleague or even patients, for example?
Sure, I'll go ahead and go first. So I'm towards the end of my career, but it doesn't mean you still can't go out and learn something and be a better clinician and act in the best interest of your patients. So I had a particular interaction with a surgeon. We had a canceled case, and it didn't go well. So I started to look for resources on this in the moment conflict management. And, it kept leading me to these sources on debate, which wasn't really what I was looking for. And I happened to be on a forum on a Reddit, and someone had mentioned, oh, actually a great way of dealing with conflict. You need to look at how police officers deal with conflict, how they deal with people that they have to give tickets to and try to de-escalate so they don't have to use force. So that led me to this book called The Verbal Judo. And it was really a story of a policeman, had a very interesting life, had to get a PhD in English, decided to become a policeman, was into martial arts. But he tells a story of how he's just thrust out there to deal with people and had no idea how to deal with that. So with his English degree and his communication skills, he developed this art of verbal judo. And he did a great job of really scripting out how they deal with somebody that they have a conflict with, somebody that they have to pull over for speeding, give a ticket, how they can resolve this peacefully. And the one example he gave was when someone uses, let's say, some disparaging phrases. Oh, you always want to cancel cases. You're just trying to get out of work. He has these things called, I think they're split phrases or slip phrases. And it's basically, you're answering the person, but you're really not giving them anywhere to go. It's kind of like Caesar on one of his war campaigns led his enemies to where there was no water and no escape. They couldn't do anything. But with these slip phrases, they're like, say, oh, there may be some truth to that, but, we need to focus on patient care, or, I appreciate you telling me that, but this is what we got to do. But anyway, just taking a step back, we can look outside of our specialty, and we can gain some skills, especially when it comes to the soft skills, the people skills. And I found it very useful.
Yeah, that sounds really interesting. I'm always really intrigued by, how we can use strategy to de-escalate and really just kind of redirect those kind of uncomfortable conversations. If you get good at that, you really have a leg up.
Oh, yeah, very much so.
I would add, I'm not an expert on this, but I would say that what has worked for me is to be sure I'm listening. People like to talk and they'll eventually run out of energy, I think, but asking questions, particularly if they're just irate but not necessarily focused, you can say, well, why? Or what do you mean? Or could you explain that better? And that tends to de-escalate. So listening would be the first thing. That I would say involve others. You could say, well, just a minute. I don't really understand that. Let me get Joe involved because I think he understands that a little bit better. So get help. And that has usually worked for me, and I think is a way to proceed.
Yeah, and the author talks about the 5 truths in all cultures. He says it spans all cultures. You don't have to deal with people depending on where they're from. And the 5 truths are: number 1, to feel they need to be respected, rather be asked than told, have a desire to know why, prefer options over threats, and always want a second chance. And that was really kind of the backbone of his strategy when he was dealing with people that were in a precarious situation.
Thank you, gentlemen. Along those same lines, what about dealing with insurance companies? Can strategy help us fight back when facing unfair payment practices or other challenges? And what might that look like?
Earl Bueno, as an anesthesiologist out of Connecticut, he wrote a wonderful article on how their whole state activated their network when Anthem tried to eliminate anesthesia charging for time. It was a great example of not accepting the status quo. It was an all hands on deck attitude. They used multiple avenues, phoning everybody in their society, working with people at the ASA. They contacted their legislatures. They engaged the PAC. They got a lot of traction via social media and the network. And, eventually what happened, unfortunately, the CEO of United Healthcare was killed. And that really kind of shut that down. But they still remain vigilant. They don't think this is going to go away. But I was very impressed on how swiftly they engaged their network, the different avenues that they used, and the fact that they didn't give up. I could see at one point where, well, we've given it over to the ASA. We're just going to see what they can do and do nothing. That's exactly what they didn't do. After they engaged the ASA, that's when they went off and started working with their legislatures. So they had a great strategy, and they continue to have a great strategy with that.
What's helped me in these situations is what I would call quick persistence. It may be that the first step of insurance company is, well, let's just deny it, whatever it is, whatever the claim is. And you need to quickly, not on a 60-day cycle or something like that, just persist and say, this is a legitimate bill, please pay it. And sometimes the communications all involve either a human element. That would be something like, well, we can't do this major surgery without anesthesia. The patient's going to scream or yell. And that humor element or that common sense element sometimes helps. But it's almost become a little bit of a game right now. And so that's worked for me and kept me sane during the process.
And do you gentlemen feel like these same sort of strategies are able to be implemented within the organizations that we work for? And how can we use them to maximize relationships with the hospitals and healthcare organizations?
Yeah, definitely. Knowing who you're talking to and knowing the language that they speak. As physicians, we focus on clinical outcomes, rightfully so. Administrators, they're focused on financial impact. I'm not saying that solely, but that's the language that they talk amongst themselves in, dollars and cents. So when you're working with them, part of your strategy is that, okay, I need to speak in terms of numbers with them, and put a price tag on what we think the financial impact will be on that. That goes a long way with them, especially when they realize, hey, they've done their homework, they're taking it seriously, as opposed to just, going in there and winging it, which is not productive for anyone.
Well, I agree with all that. And I believe in just honest communications. The honest communication is that the patient needs this. They've got cancer and they need surgery or whatever. I would say that, and you don't want to be communicating just with an AI bot from the insurance company. So I also try to escalate it to a human, and particularly a manager. So those are two other things that you need to do. Ultimately, insurance companies don't want to use up all of their time, so they will frequently recognize the truth of what you're saying and just move on in some other direction. So persistence, quick persistence, honesty, and escalation, and using human elements in your communications have all helped me.
So just a follow-up. Franklin Chow wrote a great article on how their group negotiated with the hospital for a new NORA service. And he went through the strategy that he used, the strategy he learned in his MBA studies at Cornell. So there's not just one strategy when it comes to negotiations. There's multiple ones, but you need to choose one. You just can't go in there and just, we'll figure this out. No, that's not going to be productive.
Thank you, Dr. Staggenborg. And as you can probably anticipate, hand in hand with strategy is always data. So what role does data play when we're looking to meet a challenge strategically? And why is data important when it comes to crafting a workable strategy?
Sure. So data is currency in negotiations. Going back to what I said about how administrators think in terms of numbers. We think in terms of outcomes, they think in terms of financial impact. In order to demonstrate what the financial impact, you have to do forecasts. And for those forecasts, you need data to be able to do that. Oftentimes, we rely on our own experience, and data is a way to frame and lead the forecast and the discussion with clarity.
Thank you so much, Dr. Staggenborg. This question is for Dr. Johnstone. Can you talk to us about how you feel progress is being made? And is there something that you think we could be doing better? Is there an opportunity for more growth that we're possibly not thinking about? Thinking from your perspective and the amount of time that you've been at this.
I would say that we need to proceed on the transition that we're on, which is from individual effort to team effort. We need to be building teams better, building and leading teams to improve patient care, to advance the specialty, to communicate our message. No individual can do everything alone. So I would say that understanding the importance of teams and getting involved in them is something that we need to do better. And there are just an enormous number of things that we need to solve. We have issues or even messes in anesthesia practice everywhere. Billing and collecting is too complicated. I don't believe any of my residents understand billing. We need to simplify that and explain that better. We need ORs to function better. Right now our issue is tripping and head banging in operating rooms. We need to lead teams to solve that. That needs to be solved at many levels, at the purchasing level for equipment, the organizing level for how we deliver it, and how we manage people in the operating rooms. And I would say that, that's the journey that we've been on, from individuals to team building, and we need to advance along that. And I think that building the strategies will get everybody involved, and that's a good way to proceed. We need everybody to participate in practice management, and if that's not the forte or interest of an individual, then what they need to do is cover for a colleague who can get involved and does want to get involved. So I would say those are two of the things that we need to do.
Thank you, Dr. Johnstone, and thank you for that advocacy. Before I let you gentlemen go, I'm interested in hearing about your experiences with this issue of the monitor. Is there a specific takeaway you hope readers will take away from the issue?
Sure. From a strategy standpoint, to have a plan and think in terms of, am I leaving money on the table or am I spending too much? So we have limited resources. You need to go in with a plan. As far as, writing for the monitor, I always want people to know that it's your monitor. Anybody can write an article for the monitor. It's if you have something interesting happen to you while you're working, write an article, submit it. If you need help writing it, contact somebody in the monitor. They'll have someone help you write it. But it's your monitor.
And I would just add that the person that learns the most from writing an article is usually the person that writes it. So that's great advice. I like that idea. And I would say that the beneficial future is not assured for any of us. We all need to get involved, and everybody can find a niche in an interest in one of the articles in the monitor. So thank you, Joe, for organizing this.
You're welcome. Thank you.
Thank you, Dr. Johnstone, and thank you, Dr. Staggenborg. It's been an interesting conversation, and I'm sure our listeners learned along with me. For those who want to learn more about practice management, please visit asamonitor.org and join us again soon for more Central Line.
Hi, this is Dr. Jeff Green with the ASA Patient Safety Editorial Board. Medical malpractice statistics are sobering. 1 in 3 providers will be sued over the course of their career. Anesthesiologists experience an annual rate of paid malpractice claims of 11.7 per 1,000 physician years, with 10% of paid malpractice claims reaching over $1 million. There are increasing anesthesiology claims for MAC, NORA, and office-based surgery procedures. Anesthesiologists can reduce exposure to these increasing risks for medical malpractice claims by 1. Understanding the risks of NORA and MAC anesthetics and educating stakeholders. 2. Recognizing and reducing the incidence of respiratory events in NORA and MAC anesthetics. 3. monitoring and deterring complications in the postoperative setting before rescue is required, and finally, by thoroughly examining and documenting dental disease prior to anesthesia. With these safety tips in mind, it is hoped that anesthesiologists can reduce the incidence and severity of malpractice claims in the future.
For more patient safety content, visit asahq.org/patient safety. The business of anesthesiology continues to evolve. Gather fresh perspectives, transformative technologies, and practical tools to help your anesthesia business succeed at ASA Advance each January. Get the latest info at asahq.org. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.